Dr. Crawford asked me to I guess, do a debate in terms of extolling the virtues of the NCCN prostate cancer screening and early detection guidelines. I am vice chair of the panel. I've been working with Peter Carroll for the last 4 years now, and I think that this is what I can do to frame what we try to do on prostate cancer early detection in terms of the NCCN guidelines. First off, show of hands, do folks use the NCCN guidelines? In general? So not that, how many folks don't use the NCCN guidelines? Okay, so if you don't use the NCCN guidelines, I encourage you to check out the website. It's free. You just sign up with your email, and all of the major cancers that we take care of, bladder, prostate, kidney, they're all there, and they're all there for you. Basically, if you take care of these diseases, they're very easy to use, as I'm about to go into, and I would encourage you to do that. What we've done with prostate cancer early detection is in this to frame it in the context of the USPSTF debate. When the USPSTF came out with those recommendations, which was basically screen no one, the AUA in turn came back at them and said, "What are you talking about? We've got to screen everyone," and there was polarization. And I think what Peter Carroll has really done superbly, is to try to steer us on a middle course, right down the middle, to be able to give all of you the framework and the guidelines that you need to find that balance, to be able to have equipoise when you approach these patients, but in a very, very practical kind of a way. So that's the early detection website. When you do hit on it, it comes as a PDF file, but it's got all these links embedded into it. It's very easy to navigate. This is the current panel. I think it's important to point out, look at the composition of the panel. 25 urologists, 25 folks just like you. 1 pathologist, 1 biostatistician, 1 internist, to be fair, and 1 patient advocate. And it's always fascinating to have the patient advocates on the panels, because a lot of times we'll want to be more conservative, but they'll want to be more aggressive in terms of screening. And Dr. Carlson is shaking her head, yes. And so it's a great panel. These are folks that have very spirited discussions. They come from a wide variety of backgrounds. Dr. Castle locally is on the guidelines panel. He keeps us honest. And the way that it works is that there are 30 centers that are represented. It's updated once annually, although Dr. Carroll and I are working hard behind the scenes continuously with the guidelines group based out of Philadelphia, who are doing systematic reviews and constantly updating the evidence. Changes from prior versions are always noted. So if you click on the link, it's going to have like red lines through what was there before, so that you can keep track of what we have changed. So it's all very transparent. It's very fair. It's integrated with the NCCN guidelines for localized prostate. So if you get to that point where you diagnose someone, you click on the link, it'll take you right away to the localized prostate cancer guidelines. And I can tell you, in terms of conflict of interest, it's tough. If you have a major conflict of interest, the NCCN will ask you to step off. And that has happened in the last 12 months with somebody. So it's very monitored. It's very, very well stated. We have to recuse ourselves from certain votes. And so it's very transparent in that regard. Very easy to use. This is what the first page looks like. And we work very hard to keep the algorithms very, very easy to follow. We have them up in our clinic a lot. The residents have printed out various of these algorithms and put them around. They have an office at our VA. They have them all around the office for all the guidelines, because they're easy to follow that pathway from left to right. It's very, very easy to follow the pathway. It's practical, as I said. It's all evidence-based. It's designed for clinical practice. And here's something that we just found out recently. Medicare and other payers use it for their fee schedules. So typically what will happen is, for a biomarker, for example, biomarkers, you might get a lot of pushback from insurers, and then suddenly it'll appear on the guidelines, and suddenly you're getting less pushback because they're setting their fee schedules based off of it. There are 3 general algorithms in approaching the early detection and screening. Each informs a different component of the screening process, and each one stepwise flows into the next in a very logical kind of way. And another very important point that we made earlier at the session, we are not typically the gatekeepers of the initial point of care with PSA detection. It's usually going to be the primary care providers. And so what we've done is we've tried to build it into your practice so that somebody's already come to you with a PSA elevation. What do you do now? You don't necessarily need to go charging in a biopsy, obviously, and we wouldn't recommend it, but you can use your clinical acumen in the context of the guidelines to try to sort through it. So the first algorithm pertains to PSA screening in general and what our recommendations are. Our second one pertains to indications for biopsy, and our third one pertains to interpreting the biopsy results. This is the first one. This is the landing page. And on the baseline side, there's everything that you can possibly imagine that's important to you that you already do already, H&P, family cancer history, everything else that you've all been talking about all morning. And then the second column is one of the most important because it's risk assessment and start a benefit of the discussions of prostate screening with the patient. Okay. Now, typically, they've already gone through that when they see you, but we encourage you to reinitiate the process. What does this PSA of 4.1 really mean, Mr. Smith? Sit down with them, talk to them. What I tell the primary care providers is, look, you've already crossed PSA off on your checklist. They're with us now. I've got a 30-minute new visit that's elevated PSA and nothing else. I can have a conversation with them. I think that's even-handed. And then we have age stratification in terms of PSA screening in general. We got a lot of pushback initially from the urological community about limiting PSA screening to under 75. We got pushback from our patient advocate for limiting it to under 75, and so we have expanded it, but we think in a very even-handed way so that we allow for that equipoise and that ability for you to have that conversation, individualize your conversation with your patient. You go over to this side of the column, and then you can just click on these, and it'll take you to indications for biopsy and various things that you need to do. And again, it's very logical. It just follows the arrows from one side to another. And then the next page is indications for biopsy. So you've gotten to the point where they have the elevated PSA, you're having a discussion, you're trying to decide what you're going to do, and this is the algorithm the same from this side to this side, and you follow the algorithm, and you can consider biomarkers in this column, you can consider MRI. These are all things that have been inserted gradually over the last couple of years as the evidence has accumulated, and then make the decision as to whether or not you're going to biopsy. And again, it's very simple, very straightforward. Once you get to the point where you're having the discussion about whether or not you're going to biopsy, we recommend consideration of more specific biomarkers. The ones that we currently have on the guidelines are free PSA, PHI, 4K, PCA3, and MRI. Does it mean you have to get them? No, you can consider getting them. And we only allow for biomarkers on the panel that we think have met a certain standard of evidence. Because believe me, everybody would like to have their newest biomarker on the panel, but we conform to standards of evidence. And then finally, interpretation of biopsy results. So it's pretty straightforward. Cancer, well, you just click on and go to prostate cancer. Atypia, high-grade PIN, and benign, all of which have different algorithms and different things that you can follow. Again, right there for you, right there to remind yourself. Does it mean you have to follow these? No, but it provides you an evidence-based, up-to-date framework. We have done the work for you. If the biopsy is negative, for example, you can get an MRI, you can do MRI-guided fusion biopsy, you can do a PCA3, you can do a confirm MDX, you can do a percent-free PSA, all these things that Dr. Crawford's been discussing. All these things are on there, and you can consider them. And nothing is mandated. Nothing is mandated at all in any of these guidelines. It's just suggested that you consider it. With respect to MRI, at first we were reticent to introduce it over the last couple of years, and these are various articles, the last of which in the middle, which is New England Journal of Medicine. That's a randomized clinical trial. Doesn't get any better than that, and that is evidence to support it. And I can tell you over the years, as we have moved MRI up as a consideration in the algorithm, the insurers have started pushing back less. In my practice, I have insurers pushing back much less now on getting MRIs, even in the initial conversation with the patient. Some recent updates: age stratification, family history and mutations. We're going to be adding the cancer susceptibility genes, or we have already, rather, BRCA, those sorts of things, considerations with links to other NCCN guidelines pertaining to that, and newer biomarkers. Folks are always petitioning to have their biomarkers added to the guidelines, and we have to take into account the evidence supporting them. PSA cutoff, our cutoff is 3. I'm not going to get into the weeds here as to why we chose that, but in large part it was Dr. Vickers who set the standard on that. If more data consider, you can do these other kinds of tests that are there. Prior biopsy negative, all these things. MRI, PCA3, confirm MDX, percent-free PSA, everything's there for you to consider in a very easy-to-use, updated format. And the take-home points, I would say, again, easy to use, practical, evidence-based, designed for clinical practice, designed by urologists for urologists, which is important. We understand your clinic flows. We understand what you go through every day because we do it too. And then 2 other big points I would bring up: Medicare and other payers used for fee schedules, as I noted. And you know what? It potentially provides you a medical legal shield. If you are following evidence-based guidelines that payers follow in setting fee schedules, and you document as such in your record, well, then you have done your due diligence. Thank you very much.